Name is Oluwawemi Modej, and today I'll be presenting a comprehensive psychiatric assessment of Sarah Neil, a 25-year-old female. Her chief complaint is depression. In this presentation, I'll walk you through her history, exam findings, mental status exam, differential diagnosis, and evidence-based treatment plan. Sarah is a 25-year-old female presenting with depression. She reports low mood and functional decline. On exam, she is alert and oriented ×4. Her vitals are within normal limit, though her BMI of 31 places her in the obese range. This baseline information gives us a clear starting point for our assessment. Sarah's depressive symptoms began about 2 months ago and have been worsening. She describes depressed mood, anhedonia, fatigue, insomnia, poor concentration, appetite loss with weight change. Most importantly, she admits to passive suicidal thoughts, but she denies a plan or intent. The context include work, stress, and a recent breakup. Her functional impairment is evident through missed work and social withdrawal. Sarah's past medical history includes obesity, dysmenorrhea, and a history of asthma. She has had no surgeries in the past. She has no prior psychiatric diagnosis or treatment, which means this is her first major depressive episode. Family history is significant for depression and alcohol use disorder, which raises her genetic risk. For her medication history, she currently takes loratadine as needed and has never tried psychotropic medication. She has no drug allergy. Since she has never taken antipsychotics, an AIMS assessment is not applicable in this case. Sarah lives with a roommate and maintains a close relationship with her mother. Her mother is very supportive. She works in marketing. Like Sarah works in marketing, but her absenteeism has increased due to her depressive symptoms. She does not use tobacco. She does not, she drinks rarely. She drinks alcohol rarely and denies drug use. Socially, she has withdrawn but maintains protective factors such as faith, supportive relationships, and career aspirations. Our psychiatric review is positive for depressive mood, anhedonia, fatigue, insomnia, and concentration problems. Neurologically, she only reports occasional headaches. She has no endocrine symptoms like cold intolerance and constipation. Gastrointestinal review shows decreased appetite. Cardiac and respiratory symptoms are unremarkable. On physical exam, Sarah appears well nourished, but with slowed psychomotor activity. Her HEENT, cardiovascular, respiratory, abdominal, and extremity exams are all within normal limits. Neurologically, she is fully oriented with intact cranial nerves and no motor deficits. Her physical exam overall does not point to any underlying medical condition causing her depression. So for our mental status exam, I used the aseptic mnemonic. So using the aseptic framework under appearance and behavior, Sarah is casually dressed. She is well groomed, cooperative, and slowed. She's cooperative with a slowed psychomotor activity. For her speech, she has normal volume, slowed rate, and coherent. Under emotion, her mood is down, affects constricted but congruent. Perception wise, she does not have hallucinations or illusions. Her thought process is linear and goal or directed. She has passive suicidal ideation without plan or intent. She does not have homicidal ideation as well. Under the insight and judgment, I say that is fear because she recognizes that she is depressed and needs help. Cognition wise, she is alert and oriented times 4, attention mildly slowed, memory intact with minimum prompting. This thorough mental status examination support a diagnosis of depression without psychotic features. The PHQ-9 score is 18, indicating moderately severe depression. Her GAD-7 score is 9, suggesting mild to moderate anxiety. The Columbia Suicide Severity Rating Scale identifies passive suicidal thoughts, but no intent. This indicates low acute risk. Her mood disorder questionnaire is negative, ruling out bipolar disorder. Her Odyssey score is 2. Her HUDITC score is 2. This is showing low risk alcohol use. Baseline labs are important to rule out secondary causes. Recommended workup includes CBC, CMP, TSH, B12, folate, vitamin D, lipid panel, and HbA1c. A urine pregnancy test is also indicated before initiating an SSRI in a patient of childbearing potential. An EKG may be considered if medication with cardiac effects are prescribed. My top differential is major depressive disorder, as she meets full DSM-5 criteria. Adjustment disorder with depressed mood is possible, but the severity and duration favor major depressive disorder. Persistent depressive disorder is less likely because symptoms have not persisted for 2 years. Bipolar 2 disorder is unlikely given a negative MDQ, negative major depression questionnaire. Finally, medical or substance-induced depression is ruled out with history and labs. Sarah meets DSM-5 TR criteria for major depressive disorder, single episode, moderate severity, without psychotic features. She also meets the specifier for mild anxious distress. The criteria are satisfied by depressed mood, anhedonia, sleep disturbance, appetite change, fatigue, poor concentration, guilt, and suicidal thoughts, lasting more than 2 weeks with functional impairment. In summary, Sarah is a 25-year-old woman experiencing her first major depressive episode. Her PHQ-9 score is 18 and she shows occupational and social impairment. She has passive suicidal ideation but no plan or intent, placing her at low acute but moderate chronic risk. This presentation is most consistent with major depressive disorder. So my treatment plan addresses safety, pharmacotherapy, psychotherapy, lifestyle, labs, and follow-up. Under the safety, a crisis plan is in place with support from our mother. Medication-wise, Sarah will start sertraline, which is Zoloft, 25 milligram daily. We're gonna titrate it to 50 milligram, and I will discuss the common side effects and black box warning. Therapy, cognitive behavioral therapy, CBT, and behavioral activation to build coping skills are recommended. Lifestyle-wise, I will encourage Sarah to take daily walks, and also structured activities and good sleep hygiene. For our labs, I'm going to order baseline workup as outlined above, as outlined in the previous slides. So follow up, Sarah will need to follow up in 2 weeks for safety check and 4 to 6 weeks to assess efficacy and also to repeat PHQ-9 assessment. So finally, the references I listed above, which includes the DSM-5-TR, the VA guideline for depression, the NICE guideline on adult depression, and the Cipriani's 2018 Lancet meta-analysis are all listed here. This ensures that my treatment plan is firmly grounded in evidence-based practice. Thank you so much for listening. Have a nice day.